So I'd like to welcome everybody to today's session. We're going to be talking about strategies that we can use to reduce the burden of disease in generalized myasthenia gravis, with a focus on the role for the neonatal FC receptor inhibitors. I'm joined today by my colleagues from Duke University, Dr. Carissa Gable and Ms. Missy Pittman, who's a nurse who looks after patients with myasthenia gravis. And we'll be talking today about some of the issues that these patients face. So for the first session, we'll talk about understanding the disease and the treatment burden in generalized myasthenia gravis. And to lead into that, I'll spend a bit of time talking about the overall symptomatology that patients with myasthenia gravis experience. Most patients start with ocular symptoms, either double vision or droopy eyes, ptosis, and of those, many of them will generalize, often within the first 2 or 3 years, to weakness involving the face with reduced facial expressions, to bulbar weakness with slurred speech, choking, difficulties chewing, and the potential for aspiration, which is one of the more feared complications in myasthenia. Neck weakness can produce a head drop, and generalized weakness of the arms and legs is usually proximal and symmetric, but rarely can be distal and asymmetric. Breathing is another one of the manifestations of myasthenia that we try and avoid, but certainly a diaphragm weakness can occur as a result of the disease. And finally, weakness of the extremities, which is usually proximal and symmetric. So I'd like to bring in my colleagues now and maybe ask Dr. Gable and Ms. Pittman to discuss what aspects of living with myasthenia do you find have the biggest impact on your patients?
Patients with generalized myasthenia gravis have a number of aspects that can be involved that can affect quality of life. And actually, in our clinic, we routinely use, and we'll talk about that probably a little bit later, outcome measures that include some of the primary endpoints that you see in the clinical trials, the MG-ADL score. We use the MMT and the MG composite score, but also the MG-QOL, which actually covers a lot of these things that you see here that can really affect quality of life. And so we ask our patients about that because that gives a lot of information that sometimes isn't captured by these other objective outcome measures and what we talk about in the clinical setting and the exam setting. And so what you might see that can come from that are some things, a lot of fatigue that can come along with the quality of life effects for myasthenia. Definitely one of the things that really impacts, I think, a lot of things, especially in areas where there isn't a lot of public transportation, which happens to be around here, is the impairment of driving, which is really crucial to be able to kind of do anything from errands to your job to any kind of thing that you need to do. So I think when you have a lot of double vision, that's unsafe, and that can really impair their ability to function pretty significantly. Of course, speech and swallowing difficulties are problematic because for the reasons mentioned with aspiration. Also, there's so many limitations to work-related kind of capabilities as well. It can affect with the generalized symptoms that we talked about. And that fluctuation, sort of unpredictability with muscle weakness, but also with vision changes, can be a little unnerving if sometimes patients are driving and then suddenly all of a sudden experience double vision. Some of my patients have decided just to opt out from driving in certain circumstances until things get under control.
I agree completely, and the fluctuating nature of the symptoms makes it very difficult for patients. They're always wondering, even when they're under good control, at the back of their mind is when is it going to come back, which I think is a major issue for many patients. Dr. Gable, you mentioned this earlier, but you're using several different measurement tools in your clinic. The MG-ADL is the one that's used as the primary endpoint for most of the clinical trials, including the trials on FC inhibitors. Which tools do you find most helpful and in the days of a busy clinician, most easily administered?
Right. So we've approached that with the ones that are patient-reported outcome measures. We've actually sent to the patients in advance, or you could alternate electronically through the EMR, or we also and so we have that information already incorporated into the clinic note as kind of a flow sheet that kind of just automatically pulls in all the original data fields and all the information for those four outcome measures: the MMT, the MGQOL, the ADL, and the composite scores. And so I think, even if you didn't have that kind of level of sophistication with getting those, at least patient reported, the ADL and the QOL measures, you can still get those with paper forms and just having the patients fill those out while they're in the waiting room, or having kind of the medical assistant help, get that to them before you go to see them in clinic. gives you that information, or you're already a step ahead and kind of a busy clinic of getting that information because, when you're getting all these outcome measures, sometimes that can take up a fair amount of time.
Right. And I find the MG-ADL is also very easy to administer in the clinic. You can have patients do it themselves. I tend to do it with the patient because I do like to filter it slightly. Patients will often report symptoms that are not specific to myasthenia. So the patient with florid congestive heart failure who may report shortness of breath that's clearly not related to their myasthenia. But it's easily used in the clinic. It doesn't take very long. And importantly, increasingly, the criteria for prescribing some of the more advanced biologics in myasthenia require some sort of objective measure about disease severity. And the MG-ADL seems to be the primary endpoint that's used most frequently for the trials, at least. So these are some possible treatment burdens that have been identified from the literature. Certainly the need for multiple treatments. Many patients with myasthenia are on not one, not two, but three different medications or more. It can take a long time for some of the non-steroidal immunosuppressive drugs to take effect. We have to be very careful about the administration of some of the medications in patients who are pregnant. And obviously, comorbidities is a big factor when deciding what medications may be appropriate in the management of myasthenia. So again, I wonder whether my colleagues want to comment on the burden because of the treatment.
The burden of treatment comes from a number of different factors, and I think one of them, one component is that there are still patients, although we have all these different medications previously and now even more, but there's still some patients with refractory disease that's still difficult to manage or require multiple therapies, and that can create a significant burden, as well as sort of the route of administration of these medications can create a burden as well, depending on restrictions on travel or ability to get to where they need to go, and insurance coverage for those things are some of the things that I find there are some of the unmet needs still for patients.
And the other one that I would add to that is the speed at which these various treatments work. Prednisone is effective, but in my opinion, takes several months before it produces optimal benefit. The non-steroidal immunosuppressives can take more than that, 6 to 18 months before they produce optimal benefit. And some of the newer biologics are exciting in the sense that they seem to show benefit quite early in a matter of weeks. So I think the time of onset of the various treatments that we have available is an important factor as well. Missy, do you have any thoughts?
I think too for the nonsteroidal, medication, there's a lot of lab monitoring that comes in with that, and that can be a burden for patients, the cost, the timing of that, trying to find a lab, getting the labs sent to us for review can be burdensome. That's another thing. Those drugs are great, but there's also some, high stakes management with those as well.
Ms. Pittman, what are the challenges that you hear day to day in patients with myasthenia that are embarking on treatment?
One of the main questions I get is, where are they gonna get this medication? Are they gonna be able to have a healthcare provider come to their home? Or do they prefer not having anyone come to their home and go to an infusion center? How far is that infusion center from where they live? How can they get there? We work through that a lot over the phone with these patients because it's also a matter of comfort for them, what they would be most comfortable with. And oftentimes patients, after they leave the clinic visit, especially during the first possibly 2 years of diagnosis, they hear a lot of information, but they have a lot of questions. So I'm trying to help them answer the questions and review possibly what the plan is, because when you get one to maybe a third medication, patients oftentimes get overwhelmed with information and just need reiteration and a robust response to these questions.
The treatments that we have available for myasthenia gravis are, for the most part, effective. 80 to 85% of patients have a very good response. But there's still 10 to 15% of patients who are refractory to the conventional treatments that are options that are available for myasthenia. So in this next section, we're going to talk about the clinical evidence for the use of neonatal Fc receptor inhibitors in the treatment of patients with generalized myasthenia gravis. So to understand the mechanism of the neonatal Fc receptor inhibitors, you need to understand the trafficking of immunoglobulins and the mechanism of antibodies in myasthenia gravis. So Anti-acetylcholine receptor antibodies in myasthenia are typically IgG1 or IgG3. There are several possible mechanisms, including blockade of the receptor, including cross-modulation of the receptor, and including complement binding. MuSK antibodies are typically IgG4 and bind to the antigen MuSK, which indirectly affects the function of the acetylcholine receptor, leading to reduced efficacy of neuromuscular transmission. So with different antibodies and different mechanisms of action, treatments that can reduce the level of all antibodies are potentially beneficial in the management of myasthenia gravis. And the neonatal Fc receptor inhibitors potentially fill that role. They work by inhibiting the chaperone effects of neonatal Fc receptor inhibitors within the endosome. So normally immunoglobulins are internalized into an endosome. They're then protected by binding to neonatal Fc receptor inhibitors, and they're recycled, which increases the efficiency and the half-life of immunoglobulins. The inhibition of these neonatal Fc receptor inhibitors prevents that protection, that chaperoning ability of the neonatal Fc receptors within the endosomes, leading to a greater trafficking of immunoglobulins into the lysosomes, where they are broken down and degraded. So it actually reduces by about 50% the level of immunoglobulins, including the pathogenic antibodies in myasthenia gravis. Okay, so we now have several options that are available or will soon be available for the management of patients with generalized myasthenia gravis using a neonatal Fc receptor inhibitor. Efgartigimod was the first one to become available, and you can see the dosing listed there, either IV or subcutaneously. It's generally given weekly for 4 weeks, followed by a month off, and then repeating that cycle twice more, and then with future treatments determined by the patient's response. It has a fairly rapid onset of action. The trial showed that within a week or two, many patients were improving, but optimal benefit could take up to 2 or 3 months, with some patients continuing to respond beyond that. Rozanolixizumab, again, is given weekly subcutaneously for 6 weeks, so patients like the subcutaneous administration. It's approved for patients with both AChR and MuSK myasthenia, so it does give you an option for patients who have MuSK myasthenia. Nipocalimab is given intravenously every 2 weeks, and again, it is in the process of being reviewed by the FDA, and batoclimab is being studied as well, and is given weekly subcutaneously for 6 weeks. So perhaps we'll spend a bit of time now discussing the use of neonatal Fc receptor inhibitors in generalized myasthenia gravis. And again, I'll turn to my colleague, Dr. Gable. Are there any advantages to the use of this class of treatment in patients with generalized myasthenia gravis?
A majority of the patients who have generalized myasthenia do respond to some of the therapies that are available, but then sometimes there is this treatment kind of response delay that can happen as those medications start working. So there's an advantage in the sense that these medications work a little more quickly. So if you're in that group of the lower percentage, the 10 to 15% of patients that are somewhat refractory, that's an advantage for you to go on this medication. If you're kind of a treatment naive patient, I don't know that you would start this initially because you may respond to a medication that's not as costly.
So this is data from the trial, the ADAPT trial, and again showing that in patients who were AChR antibody positive, there was a very good response rate using the primary endpoint of the MG-ADL after the first cycle. And that response rate didn't exist in patients who had seronegative myasthenia gravis, so who are AChR negative, or I think that includes the MuSK positive patients as well. So they didn't seem to improve to the same degree. Side effects or adverse effects were no more likely in the group that received efgartigimod than in the group that received placebo, including serious adverse effects or adverse effects leading to any discontinuation. The most frequent adverse effects seen in the trial were things that happen to patients typically day to day. So they get headaches, they get diarrhea, they get constipation, they develop upper respiratory tract infections and urinary tract infections, but not necessarily related to efgartigimod itself. And all of these AEs were mild to moderate. This data also shows the comparison of the subcutaneous efgartigimod versus efgartigimod IV. and again showing that the side effect profile was similar between the two, maybe slightly higher with subcutaneous versus IVIG, with the most common adverse effects being injection site reactions and headache. Here we see the data for rozanolixizumab, and again showing that the side effects were no greater in the, or not much greater in the group that received rozanolixizumab than received the placebo. And very few patients had to discontinue because of side effects. And for nipocalimab, again, using compared to placebo, using the primary endpoint of the MG-ADL, showing an improvement in the group that received nipocalimab, and side effects were no more common in the active group receiving nipocalimab than they were in the group receiving placebo. For batoclimab, again, similarly, the trial data showed improvement in the patients that received the active drug versus placebo. Side effects were fairly common in this trial. Over 90% of patients experienced any treatment emergent adverse effect, but they didn't seem to be any more common in the active group compared to placebo. And we talked earlier about the unmet needs. So how do the neonatal Fc receptor inhibitors address some of these unmet needs? So speed of response is potentially one of them.
Mm-hmm. Yep, speed of response is definitely a big factor and advantage for these particular medications. And I think the efficacy data looks pretty comparable to the other currently available treatments. And I think, as you said, unmet needs. So the side effect profile is also another kind of factor. Some of the oral steroid-sparing agents do come with risks that are not present with these particular medications that, FcRn inhibitors. And so I think you have to take that into consideration as well because their side effect profile is actually pretty good.
And Ms. Pittman, you're talking to these patients on the telephone. Are you hearing much back from them in terms of side effects or other product specific concerns?
Minimal side effects, honestly. I've only had a handful of patients who've had significant side effects and we've had to change treatment. As far as cost, I do try to work with the manufacturing company and see if there's patient assistance for these medications. And that's really helpful in trying to get these patients started, is to be able to get them some assistance financially. Yeah.
So as we've seen, there is evidence for several different neonatal Fc receptor inhibitors of efficacy in the management of myasthenia gravis using the MG-ADL as the primary endpoint. The patients do better. We're not seeing a big signal of adverse effects from these treatments, and there's no need for vaccination as opposed to some of the other biologics that are available. So for the third session, we're now going to move into some practical guidance for implementing Fc neonatal receptor inhibitor treatments in patients with generalized myasthenia gravis. We need to look at things like the frequency of administration, comorbidities, the concomitant use of other medications that may also bind to the neonatal Fc receptor inhibitor. The dosing schedule is a big one in terms of patient preference. Is this something that you give predictably and regularly, or do you give it in a cyclic fashion that is determined by the patient's response and then return back to baseline, as was the case for the original trials looking at the neonatal Fc receptor inhibitors? The need for vaccination, of course, for complement inhibitors, patients must be vaccinated against Neisseria meningitis at least 2 weeks before, whereas there are no specific vaccination requirements for the use of the neonatal Fc receptor inhibitors. Practical aspects include the time that it takes to administer each dose in the patient's home or in an infusion clinic, and then the need to be concerned about active infections either prior to or during the initiation of treatment with neonatal Fc receptor inhibitors. Dr. Gable, where do you think that these treatments are going to fit in ultimately in the treatment algorithm for patients with generalized myasthenia?
I think that it really depends on the severity of symptoms. And as you say, they do work a little more quickly than other medications. And so I think it depends on the individual patient and where, how severe their symptoms are and how quickly You need to get their symptoms under control. There are obviously, they're not at a point of crisis, but so you don't need to use plasma exchange or IVIG, but you want to kind of quickly get them under a little better control. So I think that's where I would think about using these medications, especially if a patient is on multiple medications. If you could lessen the burden of the multiple medications by having not 3 or 4 medications, but maybe 1 or 2 controlling symptoms, that might be a scenario where I would incorporate these. Um, I think, and then looking at the side effect profile and the individual patient and their comorbidities is really important too.
Right. Yeah, I agree completely. And I think you have to give the current conventional treatments time to work. And my thought was that probably by about 6 months, a newly diagnosed patient, you can probably get a sense of whether they're going to respond to the conventional treatments or not. And it's in those patients whose MG-ADL is still 6 or above or 5 or above, despite the use of multiple agents at 6 months, that I think we'll be looking to use some of these biologic agents, including the neonatal FC receptor inhibitors. I don't know, timing, does that, how quickly would you think you would jump in to use these medications?
I think, for the individual patient, so say they're a diabetic patient who wouldn't do well on, starting on steroids, for example, and, the steroid-sparing agents are going to take 6 to 9 months to take full effect, and they're, not controlled on pyridostigmine alone by any means. I think probably that's when I would go to this as an option for kind of getting things under control quickly.
So I think there's a good case to be made by, jumping in after the patient has been treated with pyridostigmine and prednisone, and maybe simultaneous with a non-steroidal immunosuppressive drug to try and get patients better faster, but ultimately, reduce the need for long-term high-dose corticosteroid use, which is really the main driver of the burden of adverse effects of the treatment of myasthenia gravis. So I think over the next year or two, we're going to see more publications that give us a little bit more guidance in terms of, who and when we should be using these biologics in the treatment of patients with generalized myasthenia gravis. But in general, are there certain types of patients that you're looking for who might be more suited to treatment with the neonatal FC receptor inhibitors, or conversely, patients that you would not consider for treatment?
Yeah, so I think, for patients, that would probably do well with this would be somewhat, or treatment with these FC receptor inhibitors would be, patients who say have kind of fair amount of, bulbar symptoms, kind of moderately, severely affected, who need, who, are diabetic and wouldn't do well with steroids and are, and they're not going to want to wait for 6 to 9 months to a year to get a full effect from those oral steroid-sparing agents. And so I think those are the patients that would be ideally suited for trying out treatment with this mechanism. Um, my hesitation for use of treatment for using this kind of mechanism of action is it actually in pregnant women, although there's been some safety data that at least that's demonstrated in kind of other diseases for at least nipocalimab. However, all of the mechanisms of it. So this is a neonatal FC receptor, and so that is the mechanism by which antibodies that protect the fetus and continue to just post delivery that are protective antibodies for the child are transmitted via this receptor. And so when you're blocking this receptor, you're likely blocking that as well, and that's been shown in some of the data for placental transfer. So I think in a pregnant woman or someone who was at pregnant childbearing age, I would be hesitant to start this medication.
Right. Okay. And Musk patients?
I think rozanolixizumab actually is MuSK positive patient approval, at
Right.
least the
Yeah.
FDA approval in the US. So I think that is an option for them. Sometimes, and MuSK patients are kind of interesting because it's IgG4 mediated, as you said. And so sometimes actually B cell depletion works so effectively in those particular patients with that mechanism to even have medication kind of pharmacologic induced remission without the requirement for retreatment or rarely retreating. But for the patients who have MuSK positive myasthenia that doesn't respond to steroids or that B cell depletion most effectively, I think that is where you could try rozanolixizumab.
Right. Okay. And then it's a bit premature to start talking about this because we've only had these agents on the market for the last year or two. But have you thought about switching patients from one agent to another, or any difficulties that we might have in co-administering these biologics with other immunotherapy agents?
Yeah, I mean, I think there are, I mean, for the most part, the side effect profile is pretty similar. Of course, the IV formulation versus sub-Q is a difference for the route of administration. And I find, if someone wants to kind of at least route administration wise switch from IV to sub-Q, that makes a lot of sense for switching. Um, yeah, I think it also is probably reasonable to attempt to switch potentially to another inhibitor if they're a good candidate for that particular treatment, but just aren't seeing a lot of response potentially to that one. You could consider that. Um, the things that with co-administration, what you don't want to have together are IVIG or immunoglobulin infusions and FcRn, because they directly kind of counteract the ability for the IgGs to recycle. And so you're going to see kind of a counteractive effect with those.
And the same would go for the use of complement inhibitors, that we would just be removing the monoclonal antibodies that we've just given to patients, so that presumably we should not be combining an antibody-mediated Fc neonatal receptor inhibitor with an antibody-mediated complement inhibitor. Now, as some of the new peptides become available, that might be interesting, is the ability to combine treatments with different mechanisms of action in
Mhm.
the small percentage of patients who are truly refractory to the conventional treatment. I think that there may be a role for that sort of combination treatment.
Mhm. Mhm.
And how do you plan on monitoring patients down the road in terms of both efficacy? We've talked a little bit about that, but also to identify any potentially emerging safety concerns.
Yeah, so as far as treatment efficacy, usually, especially early on, I'll see patients every 3 months. And then once, and using those outcome measures are very helpful for looking at kind of treatment efficacy as well. And then seeing patients frequently allows you to identify safety concerns. And of course, Missy fields all those questions about safety concerns. I don't know if you want to speak to that, maybe, Missy.
Yes, I get plenty of phone calls, either transitioning from one drug to one of these medications, or changing the dose on these, or having side effects. And I try to help, get through and weed out what is what, and then talk to the physician and then try to iron that out for them.
Yeah, I'm glad you mentioned the issue of trying to determine which symptoms are due to myasthenia and which are not, because I think that that's extremely important. That's the role of a true myasthenic clinic, or somebody with expertise in the management of myasthenia, is to not just assume automatically that all symptoms are due to myasthenia. And Missy, you must do a fair bit of that in your telephone calls, is trying
I
to
do.
triage patients. Is this myasthenia or is it not?
Yes, that's a lot of what I do, in management for patients like this. And sometimes, honestly, they just want to talk to somebody and kind of want talk through it and, get feedback on that. So with each of these medications, there's resources that I can give the patients or send to them for review. And a lot of this information is very easy to read, very easy to understand. And with the pharmacies that help with these medications, work one-on-one with the actual pharmacist. And they're willing to call patients too and do additional training, education, answering questions. So there's a lot of times a triangle between me and the pharmacy and the patient to make sure they get all their questions answered that way.
So as we've just heard, I think there's definitely going to be a role for the neonatal Fc receptor inhibitors in the management of myasthenia. What exactly that role will be remains to be seen. But I think most practitioners will probably slot them somewhere between the second and third or fourth line treatments of myasthenia gravis. And I'd like to thank both my co-panelists, both Missy Pittman as well as Dr. Carissa Gable, for their help, their expertise in presenting this session on generalized myasthenia gravis today.